Thank you. Thank you for the invitation. Well, first I want to say that with my presentation, I'm not going into anything that Aldo Toni said. I completely agree with him. I'm just giving my talk about metal-on-metal bearings and the lessons I learned in about 18 years. So all this is also metal-on-metal, but not really what we needed to. Is all metal-on-metal okay? While the factors that are influencing the metal debris we have of metal-on-metal are because of different issues. You have the implant design, metallurgy, clearance, and the coverage angle are very important. You have the implant position. I think it's even more important. It's technical, it's instruments. Activity, does it play a role with metal-on-metal? And what is the follow-up of these prostheses? Do we have already quite some results with this or not? What about metallurgy? In the beginning, there was a lot of debate about this. Today, we can say that all resurfacings and metal-on-metal total hips are high carbide with a high carbon alloy and a high carbide surface area content. This should be like this, and there is no difference with heat treatments. One of the first prostheses was an Endoplus prosthesis. It was a low carbon alloy and it failed. This is another implant, M2A Biomed Cup. It has had sometimes low carbon or no carbon, and this failed too. Here you see the structure. There are no carbides in the surface. This was the worst design I ever saw. It's a McMinn device from 1996, was prior to the Birmingham. You see a lot of osteolysis, and you see here the very high wear in comparison with the other ones that were a normal wear and a steady state wear of the prosthesis. And if you see the surface area, you see here Birmingham with the carbides. This resurfacing had none. But today they are all high carbon, high carbide, so no problem anymore. And you see that they can work. Here you see Peter Ring with 3 prostheses that are more than 20 years while working, also because the cup was in a good position. Here you see a lady that, in the meantime, she died, but I followed her up in my practice with 34 years, McKee Farrar, and the other one 33 years with undetectable metal ions, so no wear or very slight wear. I started 18 years ago with a Metasol device. If you look to the survival at 15 to 17 years, we have today 96%. And in most of the patients I see back more than 10 years, they have also undetectable levels of cobalt and chrome. Here you see the Metasol structure with the small spherical carbides. So that's a little bit about metallurgy and what was a debate in the beginning. But what went wrong with metal-on-metal? While resurfacing and large head metal-on-metal total hips were done by all surgeons, and the escape we had for resurfacing with the modular head became a standard metal-on-metal THR. That has been completely wrong. It was not made for total hip. And we had a big non-understanding about the smaller coverage angle of those cups in resurfacing and the big metal-on-metal hips. So 3 problems. Well, the large head metal-on-metal, they were done by all, and they had a small coverage angle. Trunnion problems, the first one I saw in 2008 with cemented stem in Birmingham. The conclusion is, and I can follow Dr. Toni with this, with larger ceramic on ceramic heads today, metal-on-metal total hip is not done anymore. And I think maybe it should never be done unless it was a Metasol device. The second one is, while we are now with resurfacing only, too small coverage angle of the cups. Of course, the worst one was the ASR. It's a technically difficult procedure, still today for me. Conclusion, well done, technically good implant works well. And the third problem we can't do anything about, it can't be tested, it's metal allergy. It's the only thing what is not really in our hands. I see it's 1 in 60 in females and 1 in 1,000 with males. If you have a female that tells you she has allergy to cheap jewelry, we have the consensus, don't do metal on metal. But what is now my clinical experience with resurfacing? Well, I started 16 years ago because if you see the Swedish HIP register of 2013, we still have, in 13 years, not more than 85% of survival of a total hip. I've done today more than 16 years, about more than 4,000 resurfacings, quite some different brands. And we looked up retrospectively to the first 249 Birminghams that were more than 10 years. And you see you have a good overall survival, even including my learning curve. The men are doing exceptional. You have practically 99% at 13 years with high activity, with practically a normal Harris hip score. Women have less good results, and we see that the risk factors are smaller sizes than 50 and females older than 55. If we go to the lower age, also in females, we see a good result and no gender difference. And what we didn't know when we started, but we know now from our practical studies we did, is that metal ions decrease with time, so wear decreases with time. The most detailed HIP register, which is the AGR of Australia, shows you that the 10 years here with the Birmingham revision rate is doing very well and doing better than a lot of total hips. If you look to the consecutive metal ion levels of chromium and cobalt in the blood, we see that they decrease with time and they are not dependent on activity. High activity or low activity doesn't make a change in wear of these resurfacing prostheses. If I look to the Birminghams between 10 and 16-year follow-up, we see 16% of the patients have an undetectable limit of chrome and cobalt. If I go to my Birminghams from 12, 16 years, we see that 27% of the patients have undetectable limits. And this is because the running in, you form a patch here on the prosthesis. This patch will grow. And as long as it stays within your cup, you have decreasing metal ion levels until the moment you have no contact area anymore between cup and head, and you get undetectable limits. So for me, with our practical studies we did, metal-on-metal resurfacing, and here with the Birmingham, it's the first proven prosthesis with decreasing wear in time. But the negative are the females, only 80% of survival. And the reason is the too small coverage angle of cup in females with the smaller sizes. Here you see the coverage angle, where in the Birmingham, small sizes, and of course the ASR was really bad, the coverage, you get into problems. We find this out because we didn't know before. In 2008, when we saw that the cups in females in an abduction angle higher than 50, so I put them too steep, we had much more outliers with Birmingham, and we didn't see them with Conserve. And the reason we didn't know why until we find out that the coverage angle was too small with the small sizes of Birmingham. We did a comparative study from prosthesis from 5 to 10 years done by me, so one surgeon, same practice, same period of time between Conserve and Birmingham. The age group was just the same. We had more females with Conserve than Birmingham, so we should have had worse results with the Conserve. Plasma cobalt levels were the same. Those are very good levels. They are below 4 for one resurfacing, 4 microgram a liter or 4 parts per billion are okay for one resurfacing. The failures, I had 2.71 per 3. They are raw data. I don't know if this really is statistical, but if you see the reason why is mainly wear issue. And that's again because of the small coverage angle in female patients. I did about 169 revisions now of resurfacing, about 50 of my own resurfacings, patients coming from everywhere. And you see here again that the main reason for revision and resurfacing, it's wear. Wear because of the prosthesis or mainly because of technical issues. I did also a randomized study with 180 implants of 9 different brands. And you see that, in fact, most of them, they are all working very nicely with small wear, lower than 4 micron, with the worst, of course, ASR. And the best was Durham, because of coverage angle and maybe metallurgy. So where we are today, Axis hip has still non-solved problems. The Adapt, I think it's okay, this prosthesis, but you don't have sizes lower than 46 head diameter. ASR, it's taken off the market, we call it the horror hip. Birmingham, we just discussed with small sizes, coverage angle, that's a little bit too low. These ones were taken off the market, even where Durham was doing the best of all in our study, and the other ones have no proven follow-up yet.
Now I stand here before you. What you see is a body crafted to perfection. A pair of legs engineered to defy the laws of physics. And a mindset to master the most epic of splits.
I just wanted to show this small video because this is a publicity for Volvo trucks. I think if we need to keep resurfacing, it's for high impact young people, mainly male people, I think also young female people. And this was not for me just a publicity of Volvo trucks that has been looked for more than 100 million people. For me, this is still to keep resurfacing there. This was 8 months after resurfacing. We have a consensus book that we made through the 2 last resurfacing courses we had in Ghent, to a very big international faculty, having done more than 90,000 resurfacings, where you still can do resurfacing and where not to do it, what is bad, what is good. And you can find in this book a 16-year experience, if you want. So just to conclude with metal on metal, I think still okay. There is no cancer risk, there are no problem babies. Pseudotumor is mainly a surgeon problem. It can be evaluated by blood sample, and the only downside is allergy. But in the 2 registers of NGR and AGR, there is just one thing that came up. They were looking into cancer risk, where they saw there is not any bigger cancer risk in metal on metal. But they saw that resurfacing procedures had a lower risk of death. And maybe he was a little bit biased in the beginning, but in Oxford, the university that really has bad results with resurfacing, they took all the bias out and they came to the conclusion that you need to do 23 male patients to do more with the resurfacing rather than cemented in order to attain 1 less death by 6 years. So maybe in the future, that's another issue we have with resurfacing. I invite you next year and the coming 3 years for our next resurfacing course. Thank you.